Hi, everybody. I'm Leslie, and I am very happy to see you all here. Welcome to our first presentation of 2024. We are happy that you are all here. I want to say a special thank you and hello to HPNA Phoenix. I know that somebody was going to be joining us, hopefully from the New York HPNA, and the New Jersey Healthcare Quality Institute was also going to try and join. So thank you guys for being here and for your support, and everyone here for our presentation on caring for persons with differing abilities. This is a topic that we decided on because we found that it's a complex and very misunderstood subject. Our hope tonight is that we can engage in some conversation and give you guys some takeaway tools so that you can help bring some clarity to your own clinical practice when you're dealing with these really challenging situations. So, we should be having can we screen share our slide presentation? There we go. All right. All right. So now I will take a quick minute to introduce our chapter members, our committee members, our chair members. I'll start with myself. I am the president, and I just wanted to give you a little history about our chapter. In 2019, we came together as a group of professionals looking to start a chapter here in New Jersey. We were able to be granted as a full chapter in 2021. And since then, we have put on several different educational programs, including Hospice 101. We had a presentation of Jen Silent, the movie, and we also had a presentation by Dr. Jessica Zitter, Caregiver, A Love Story, which are all, there's information about most of the programs that we've done on our Nursing Network site that you can refer to. There's resources there, and we welcome you to visit our Nursing Network site, and hopefully you'll join our chapter and, become an active member and kind of help us spread the word of, palliative and hospice. Next, I would like to speak to our educator, Donna Fahey. She couldn't be with us tonight, but she is responsible for this subject matter. She gave us a bunch of choices of different topics, and we chose this one. And she works for Samaritan Life Enhancing Care, and she's responsible for getting us the continuing education for this program. Next, we have Melissa, our secretary, can introduce herself.
Yep, so I introduced myself earlier, but my name is Melissa Garrido. I'm APN secretary for our chapter. And I just want to let everyone know that all our meeting minutes, agendas are posted in our website. If you have any questions, our mission and vision statements are also in the website, so you can go there and review previous meeting minutes from our chapter.
Thank you. And next up, we have Adrienne Alate, our IT person extraordinaire.
Hello, everyone. So I come from the field of technology and education. I was a district administrator for technology, overseeing the whole district. And I find that with IT, you can be the friend of many and the enemy of a few. And so I've recently purchased a $2,500 MacBook Pro, and it is now broken. And so it's in the shop. So I'm actually navigating this meeting the best I can from a phone. Some of the features are here and some are not. So again, technology can be your friend and it cannot be your friend, but I think we're making it work. But outside of that, I am an end-of-life doula, and I enjoy being in this end-of-life space as a speaker, a facilitator, a writer, an advocate, a friend, all that good stuff to those with advanced stage illnesses as well as their family, loved ones. And their care communities. And so I'm excited to be here as well.
Thanks, Adrian. And I'm going to give a shout out to Ryan Murphy. He is our former treasurer, and he has been with us since day one. He is one of our founding members, and I just wanted to say he's here, but he's minding the family. So he's listening in, and we're happy that he's here, and he is a very valuable member of our chapter. So we appreciate you, Ryan. Thanks for being here. And then lastly, we have Tracy, our treasurer.
Hi, I also introduced myself earlier. I took the baton as treasurer from Ryan, and that started this year. So I am very happy to say that I've, moved up in my role here with the chapter. With that said, I am going to give you a quick treasurer's report. All of our financial reports were submitted to HPNA for the end of 2023. I have renewed the chapter status and paid the renewal fees for HPNA last month. Our membership account balance is $1,110.46, and our donation account is $113.58, totaling an overall balance of $1,224.04. We do have plans for fundraising events this year, so please keep a lookout for that. And if you would like to make a donation to this chapter, please go to our Nursing Network website and you will see a button to make a donation on the homepage.
Thanks, Tracy. And we can we fast forward 2 slides?
You want housekeeping, Leslie?
Oh, yeah. Yes, please. Thank you. So I'll just speak quickly. We're going to be recording this webinar, if you hadn't noticed. I think when you came in, it said that the program was being recorded. We are going to keep everybody's phone lines muted. And if you have any questions or you want to make a statement or a comment, you can please put it in the chat. Melissa will be manning the chat for us. The presentation will be later posted on our Nursing Network site, so you will be able to refer back to it with the resources and all. So now, and just so you know, there we go.
So you want it on the door prize?
Yes, please. Next, we're going to have our door prize. So we have a activity that Adrian's going to hopefully be able to do for us. Yes, Adrian?
Just give me a second to pull it up.
Okay. Will it come up with the screen share up already?
It will. Just give me 1 second though.
Okay. So we're gonna have a door prize. We are raffling off a $25 Amazon gift card. It's gonna be a random selection, and then we'll have another door prize at the end of our presentation. There's no test involved, so you don't have to answer anything correctly. It's just a door prize.
All right, can you all see that?
And there we go. Tap to spin.
Okay. So here's the deal. I put 43 names, everyone who registered.
Mm-hmm.
And so I just want you all to see, make sure your name is on here. If someone registered and they're not here, we're going to pick another name. So I'm going to start again just to make sure that this is, important as far as I'm concerned. I'm going to just go through these names again so that way you can see all the names are in here.
Oh, wait, do it again. You did it. Okay, there you go. Now do it. Oh, beautiful.
Okay.
Okay.
All right, $25.
Mm-hmm.
And again, if someone's name comes up, I'm going to take it out and hopefully the person is here. If not, we'll do it again. So I'm going to shuffle the names.
Okay.
Names are being shuffled. And then I'm going to hit the spin button. $25.
I don't
Oh my God. Who's that?
see,
Donna.
do you see something? Oh, I didn't see anything spinning. Sorry. There we go.
So
All
Donna,
right.
you're the first winner. You see
All right.
that?
Oh my gosh, I do now.
Congratulations.
There you go. Congratulations.
Yeah.
All right. Let the party begin. All right, so the overview, we are going to have a group discussion. We're going to have a case study and we're going to have some breakout rooms as well. Tracy's going to be our presenter. She's going to go through this program with us and then I will wrap it up with a conclusion and hopefully you guys will enjoy this presentation and get a lot out of it. Okay, Tracy, take it away.
Okay. Is there a way to click to the next slide to do a slideshow or no?
Yeah.
Yeah.
Hold on one second.
Mhm.
This one, Tracy?
I see overview, but I don't see in the slideshow.
Oh, are we not seeing continuing education credits?
No, I don't see that.
Okay. hold on.
It's slide 8.
Oh, you want slide 8?
Yes.
Are you able to put it into presentation mode?
Slideshow start now?
Yes, I'm like clicking it on my end.
Oh, it's
Do
Do
you
not.
you have to
screen
not
sharing.
enable editing before it will go into presentation mode?
That's what I
Okay.
was wondering.
I'm gonna end the show. Start it again. All right. I'm gonna stop my sharing and then I'm gonna reshare.
Okay. Minor technical difficulties.
All right.
Here we go.
Yay.
Beautiful. All right.
Okay. You can actually that's fine. Okay, so the name of our case study tonight is Navigating End of Life Needs for Persons with Differing Abilities. It's a case study analysis and a contact hour activity. Okay. Samaritan is providing a 1.0 NCPD credit and a certificate of completion. You can obtain the CEU by writing your name, discipline, and email in the chat, attend the full program, participate in discussion, and complete the program evaluation. The certificates will be sent via email from Samaritan within 2 weeks of this presentation. And if you have any, if you're not comfortable with putting your name and all that information in the chat, you can write to Melissa in the chat privately. This is our conflict of interest and disclosure statement. Our presenters today and the planning committee represent no financial relationship with ineligible companies, no commercial support, no non-endorsement of products, no off-label use of medication, and no legal advice. This is our program description. For a variety of reasons, including clinician bias and communication difficulties, many people with differing intellectual and mental abilities are excluded from critical conversations regarding their health and life. This case study and accompanied discussion provide the opportunity to explore the complexities and unique considerations in ensuring ethical and practical end-of-life care in the context of intellectual disabilities, ID. Some of the key topics we will be discussing include intraprofessional collaboration, effective communication, ethical concerns such as autonomy and beneficence, shared decision-making and capacity, and person-centered care. we will define 4 ethical principles of patient-centered care, discuss how to determine capacity, discuss utilizing surrogate decision makers, and we expect that you will use what you learned today as tools in your clinical practice. We're going to start off by doing a group discussion. Please share an experience where you cared for a patient with a serious illness who had a differing ability, such as a mental illness or an intellectual disability. You may raise your hand and Melissa will call on you, or you can write your answer in the chat. Anybody? Leslie raised her hand.
Okay, I'll break the ice. So I had a situation. I had a patient that we were consulted on to make a decision about whether or not he was going to remain on the high flow nasal cannula, or if he was going to be intubated, or if he was going to have some other interventions. The patient was able to have a conversation with me. He was able to acknowledge that he recognized that he was really sick. He was able to, express to me that he was very sick, but it was questionable about whether or not he understood the implications of coming off of the high flow. So he had a relative who came who really wanted him to make his own decisions. So it became difficult for us to determine if he were able to make those decisions or not. I had a long conversation with the family member, and we decided that we would kind of discuss with him in generalities what was going on. But I did impress upon the family member that it would be really more appropriate for him to make these decisions for his brother, because he wasn't able to make those decisions. I was not, at the time, I was not able to determine definitively if he had capacity or not. I didn't have the tools at the time. I wasn't as informed as I am today. So it was one of those situations where I found early on in my career that there was a lot more that I needed to learn in order to be able to care for patients with questionable capacity and intellectual disabilities.
Thank you. I don't know, did anybody write in the chat?
I can speak, Tracy.
Okay.
So I have a patient who, Leslie, I saw in an inpatient setting, and the patient lives in a group home and had his brother as his healthcare proxy. So his brother has been making decisions for him all his life. And when I initially spoke with the brother said that he has some kind of cognitive disability his whole life. So comes to a point where this patient now needs a feeding tube because he's aspirating, and the brother couldn't make any decision as to the feeding tube. And he wanted us to speak with the patient and have the patient make a decision. But I said to him, you have been making decisions for your brother his whole life because it was determined that he cannot make decisions for himself, but he still couldn't make a decision for himself. So he flew in from out of state. He came in, like during meal times, he will be there. He will try to see if he can eat. So until finally he said to me, I cannot make a decision. So I said to him that, in my opinion, your brother does not have any decision-making capacity, but I would call, our psychiatrist to give us, a second opinion on whether your brother has decision-making capacity. And unfortunately, if he does not have any decision-making capacity, you will have to make decisions for him. So called psych. Psych said he does not have any decision-making capacity, and so we tried to lower down his oxygenation. Fortunately, after the pulmonologist saw him, we were able to lower down his oxygen need. And eventually, thank goodness, the patient was able to eat on his own. So we did not need to make a decision um, on the feeding tube, but the brother made at least completed a post to say, that the patient is do not resuscitate, do not intubate with limited treatment. And he said no feeding tube in the post. And so the patient did well, and he was discharged back to his group home. And that's it.
I see that Rosemary wrote, excuse me, I care homes for multiple patients that reside in group, I guess, in group homes. Rosemary, do you
This
have?
is Rosemary. Can you hear me?
Yes.
Okay, so I see multiple patients that live in the ARC group homes, and they've been institutionalized almost their whole entire life. Some of them, very few of them have any family to make decisions for them. But they have a state guardian, which makes any kind of advanced care planning impossible.
Oh,
They require, according to the guardian that I spoke with multiple times, because she's the guardian for, several of the men that live in the group home, that they will consider a DNR when the patient is ill in the hospital and an ethics committee has been called.
no, it's sad.
Very frustrating.
I come from I'm in the hospice, so when I do have these people with intellectual disabilities, they've already been signed on to hospice. I've had 2 cases recently. One, the woman also had Alzheimer's disease. So she had an intellectual disability with Alzheimer's disease, and her parents were alive, and they made all her decisions for her and put her on hospice. The other man was young. I think he was in his 50s, and he had lived in group homes his whole life, but his parents were still his decision makers. So they moved them to our hospice. But where we really had to advocate for him was that he was used to living in his group home where he had like activities and things like that. So we had to advocate for him, for his parents, to allow him to be moved to a nursing home so that he would have access to other people, other residents, and have the ability to have recreation type activities. And he was moved, his parents agreed, and we know that he stayed on hospice. We visited him there, but and he had a good death at that nursing home. But that's the extent of my experiences. By the time I get them, the decisions have already been made for them to go on to hospice.
All right. Well, we appreciate everyone who shared. Thank you, Tracy, as well. Did you want to move forward? And I'm thinking we may want to just do the one breakout room. But I think in order to keep mindful of our time, we should move forward with the case study.
Okay, well, let me do these useful definitions.
Sure.
Okay, so an intellectual disability, ID, is a condition characterized by a significant limitations in both intellectual functioning and adaptive behavior. Someone with an intellectual disability may have an IQ less than 70, and the disability is evident before 22 years of age. ID was formerly called mental retardation. Intellectual functioning refers to general mental capacities such as learning, reasoning, and problem solving. Those with an intellectual disability have lower intellectual functioning, whereas they have difficulty with the ability to learn, reason, problem solve, and other skills. Adaptive behavior is the collection of conceptual, social, and practice skills that are learned and performed by people in their everyday lives. Those with ID also have difficulty with adaptive behavior, which includes social skills and life skills. Depending on how severe the ID is, will determine how maladaptive their behavior will be. Beneficence. The principle of beneficence is the obligation of healthcare providers to act for the benefit of the patient. This principle guides us to do what is best for the patient. Beneficence protects and defends the right of others, prevents harm, removes conditions that will cause harm, helps persons with disabilities, and rescue persons in danger. It is worth emphasizing that in distinction to non-maleficence, the language here is one of positive requirements. The principle calls for not just avoiding harm, but also to benefit the patients and promote their welfare. Next slide. Non-maleficence is the obligation of a healthcare provider not to harm the patient. This simply stated principle supports several moral rules. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, and do not deprive others the goods of life. The practical application of non-maleficence is for medical providers to weigh the benefits against burdens of all interventions and treatments, and to choose those that are appropriately burdensome, and to choose the best course of action for that patient. This is particularly important and pertinent in difficult end-of-life care decisions on withholding and withdrawing life-sustaining treatments, medically administered nutrition and hydration, and in pain and other symptom control. Autonomy. All persons have intrinsic and unconditional worth, and therefore should have the power to make rational decisions and moral choices, and each should be allowed to exercise his or her own capacity for self-determination. Every human being of adult years and sound mind has the right to determine what shall be done with his or her own body. Justice is generally interpreted as fair, equitable, and appropriate treatments of persons. Of the several categories of justice, the one that is most pertinent to clinical ethics is distributive justice. Distributive justice refers to the fair, equitable, and appropriate distribution of healthcare resources determined by justified norms that structure the terms of social cooperation. Capacity is defined as a functional determination that an individual is or is not capable of making a medical decision within a given situation. This is relative to the baseline abilities of the patient. It pertains only to the current situation, and it takes into consideration the severity of the possible consequences. Competency is defined as the ability of an individual to participate in legal proceedings. Legal competence is presumed. To disprove an individual's competence requires a hearing and presentation of evidence. Competence is determined by a judge and never determined by medical providers. Here is a decision-making hierarchy which would be used when looking for someone to make a healthcare decision for someone who does not have the decision-making capacity. Number one is spouse or partner in civil union or a domestic partner if not legally separated from the patient. 2 is a son or daughter, 18 years of age or older. 3 is a parent. 4 is brother or sister, 18 years of age or older. 5 is the next closest relative. This decision-making hierarchy is not stated here to reflect any documented law. It is the general process by which healthcare decision makers are chosen for those who cannot speak for themselves. Each organization has a policy which states the hierarchy of decision-making for their patients and families. Please refer to your policy at your organization. Now we're going to talk about the subject of our case study. His name is Jimmy. Jimmy is a 78-year-old man with severe intellectual disability and with sepsis due to aspiration pneumonia. He is admitted to the hospital, and during the hospitalization, he was diagnosed with widely metastatic cancer, most likely of pancreatic origin. He was initially brought to the hospital by emergency medical services after his primary direct support person noted a fever of 103, and Jimmy was having difficulty catching his breath. Jimmy is a resident of a small residential group home with 2 other individuals with intellectual disabilities, and he's there with his direct support persons. Jimmy has lived in his home for 10 years, over 10 years. He enjoys spending time with his family, primarily his sister Clara and niece Jackie, who live in another state. He enjoys listening and dancing to music, especially Elvis Presley, feeding his fish, and eating ice cream. Jimmy's primary community nurse, Jill, and direct support person, Amani, are very involved and are often present at his bedside. His prognosis is estimated to be poor. He responds well to antibiotics for sepsis, but he is considered a poor candidate for cancer-directed therapies. Hospice is recommended by the oncologist to the medical team. Next slide. We are going to be take a look at these questions here. We're going to break out into breakout rooms shortly, and we will be discussing these questions. There will be one of us in there, facilitator, to assist with the questions and the discussion. But these are things that we're going to be, these are the questions that we'll be looking at. Who should be involved in making Jimmy's medical decisions? Who assumes the role of primary caregiver? What ethical principles drives decision-making? And should Jimmy be allowed to make his own healthcare decisions? Next slide. We will be, I'm sorry.
I'm sorry. No, I'm sorry. I'm gonna put the breakout rooms together, and
Okay.
you'll each be assigned to a breakout room. And like Tracy said, there'll be a facilitator. Then you will report back to us in our group discussion after the breakout rooms are done. It'll be about a 10-minute breakout.
Okay.
So let me. Right. There we go.
And just join your,
And then you just join your group. I hope everyone is prompted to join a group. Is everybody in a group, I hope? Okay, so I think we just have one breakout room still to come back. All right, I think everybody's back.
Yep, that was fun. I asked, Rosemary will be our speaker to discuss what we were just talking about.
Mhm.
Let's see, where are you, Rosemary?
I got it. Okay, I unmuted my. Do you want to go back to the questions and then we'll go through them one by one?
Sure.
Yeah, that's a good idea. So that would be slide number 24.
Yes.
Well, when we get to that slide, I'll read the question for now. The first question was, who is the decision maker for Jimmy?
Okay, so we all agreed that everybody on the sister, the niece, the support person, and the visiting nurse should all be included in the discussion. But ultimately, if the sister would be the one making the decisions.
Mhm. Okay, and I think we were in agreement with that in our breakout session as well. All right, next question was, what ethical principle are we addressing here in this conversation with Jimmy?
Well, we sort of had two answers. One is beneficence, because we're acting in his best interest by not putting him through the chemotherapy that was not gonna, improve his quality of life, but also autonomy. As he's certainly not, he hasn't been able to care for himself, which is why he lives in a group home.
Mhm. Mhm.
So.
Yeah, our group was pretty much in agreement with that. Melissa, did you guys have a person that you chose to speak for your group?
No, actually, we got like a long conversation about, who's the medical decision maker
Mhm.
with Jimmy, because, our case discussion really did not discuss whether Jimmy has an advance directive or not, or was the, if a surrogate decision maker has been appointed for Jimmy. So, sometimes they can have like a cousin, a sister, an aunt, but if there is a court appointed surrogate decision maker for Jimmy or an advance directive or a living will, then we have to go to that person who was appointed for Jimmy as the decision makers. And so, we had a long discussion, about that. And so, so if no, if there's no surrogate decision maker, then it would be the family.
Mhm. Right, and we kind of talked a lot about that in our group as well. And the last question we talked about was, should Jimmy be able to make his own healthcare decisions? I think we agreed that it would have to first be determined who was making his decisions for him up to this point. Was he making his own decisions, or like you said, Melissa, does he have an advance directive, or have there
Does he
even
have
been-
capacity?
Exactly. Which is brings us right to our next section of our program.
Yes.
Yeah, Tracy's got that. Go for it.
Okay, that would be slide 27, but I have it here. Capacity. Capacity is valid only within the time, place, and situation in which the evaluation took place. It is a snapshot in time. Anyone on the healthcare team, nurse, social worker, provider, speech and physical therapist can identify a person who may lack capacity, and then they could be officially assessed by the provider.
Tracy,
Good.
I'm sorry, hold on one second. Melissa, we're not seeing your screen if you're
That's what I
advancing.
was gonna ask. Are you not seeing my screen?
We see
No.
group discussion. We are up to slide, your screen shows slide
I'm,
14.
Huh? I'm on capacity on my screen here.
Oh, it
Are
says
you
group
not seeing
discussion.
capacity?
Mm-mm.
No.
All right. I'm
No.
gonna-
We're on slide 13.
Okay, I'm gonna stop sharing again. And then share screen again. And then resume slideshow. And are you not seeing my screen? Where it says capacity?
We see the
Yeah.
same slide that we saw before. It's not on, it's not moving, advancing at all.
Okay, hold on.
So, but you can go ahead, Tracy, you can keep talking about capacity while we try to figure this out.
Okay, so for example, a patient with a history of dementia does not automatically lack capacity. At the time of the capacity assessment, they may be lucid and are able to participate meaningfully in the discussion. This may potentially indicate that they have capacity for decision-making in that present moment. However, 2 weeks into the future, that same patient may be disoriented to such a degree that the individual is then found to lack the capacity for decision-making. And this is also similar to a person who is intoxicated. The person may not have decision-making capacity at the time he or she is intoxicated, but the individual may have the capacity for decision-making when he or she is clinically sober.
I just experienced something similar to that as a doula, where the husband had been put into a community group home because his wife was unable to care for him at home. But then what we uncovered later was that she was having some addiction issues, dual addiction to pain medicine and to alcohol. And it would all depend. So to me, it's very confusing how to move forward, because if you would talk to her in the morning, she clearly seemed to have capacity. And in the afternoon or the evening, which is when, you know, he had a couple of falls in the evenings, she clearly was not capable, because she couldn't even hardly communicate. So I could see this is so complex. You know, do you make those kinds of decisions that often? Does it go on a day-to-day basis of determining capacity? And how would you deal with that? The hospice organization, I actually knew more information about the family and the patient than the hospice organization, and I shared information freely with them, but I wasn't getting direction or guidance really from the hospice either.
Well, that would be our next slide for how to assess for capacity. Anyone in the healthcare team can see that a person is lacking capacity. However, only a licensed advanced practice nurse, physician, and physician's assistant can determine the capacity. A patient proves capacity by demonstrating the following. Are they understanding information relevant to the decisions in question? Do they have the ability to weigh the risks and benefits to assess alternative options? Can they communicate clearly with medical providers and about the decisions in question? And can they verbalize the ultimate decision for consistency of logic and decision-making throughout their encounter? These are some of the questions that would be asking to determine the patient's ability to understand treatment and care options, as you can see here. They're open-ended questions that elicit independent responses. They're keeping the language simple, avoid medical jargon, understanding health literacy may be limited, but they can still understand the implications of the decision. Next slide. Here's some more questions. Questions to determine the patient's ability to appreciate how that information applies to his or her own situation. These questions will help to determine the patient's ability to appreciate how the information applies to them. Again, open-ended questions lead to a more accurate assessment of capacity. When documenting capacity, the documentation must include the specific questions asked to validate your assessment. And please be sure that you detail this documentation with detail for the protection of the patient, yourself, and the healthcare team. Next slide. And we're going to continue with the case study. It'll answer a lot of questions that we had when we were in our little breakout room. Jimmy's parents are deceased. Clara, his sister, is determined to be his legal surrogate decision maker. His condition is considered terminal and not because of his ID, and discussions about hospice take place. The hospice and palliative care team guides his family, his DSPs, and community caseworkers to include Jimmy in that decision process as much as possible. Jimmy understands death, and he understands his parents have died. His DSPs and his sister explain to the healthcare team that he doesn't have a strong concept of time and often interprets it very literally. Therefore, discussing his prognosis in terms of weeks would just increase distress. It is decided to discuss his prognosis around special dates and holidays. Jimmy is supported in making his goals and preferences known with his sister and primary DSP, Amani, who is present. It is explained that he has cancer and he will die from it. He tells the healthcare team that it is most important to be home and spend time with his friends and favorite fish. Jimmy's sister wants to support her brother's wishes and desires for him to return to his home. The process of hospice and their support provided is discussed in detail with his DSP and family. His DSP, Amani, expressed increased comfort in taking care of him at home with the support in place to help guide his care. Jimmy is discharged to his home later the following day with hospice support. He dies peacefully within 3 weeks while surrounded by his family and friends and his favorite fish. Grief and bereavement support is provided to Jimmy's family, friends, and the DSP. Next slide. Is there time for us to go into another breakout room?
Yeah, I think we have time. It's 8 o'clock, so we can do another 10-minute breakout room.
Okay.
Okay.
So we'll discuss these questions when we get in there.
Mhm. So what happens if he has limited capacity? What if he has waxing and waning capacity? And when do we involve the ethics committee? All right, so let me pull these breakout rooms together. Oh, here we go. Open all rooms. All right, your rooms are open. You can join. All right, looks like we're all back. So do you guys want to talk a little bit? Tracy, you want to kind of facilitate what people were able to talk about in their groups?
Sure. We were saying, that one thing that we said that is Jimmy really, there really is no such thing as waxing and waning capacity with the ID population. Maybe in other, other cases like the alcoholic or the drug user, but not necessarily with intellectual disabilities. And we discussed, would we include Jimmy in these discussions, but it would depend on the whole big picture. Would he get upset by any of this information? Would it cause behavioral problems? So it would be unique to his particular situation of what was happening. And also the discussion of when do we need to involve an ethics committee? Because I was saying I come from hospice and we do have ethics committees. One was addressed recently. One situation was addressed with the ethics committee recently, but generally I would guess people think would see that more in a hospital setting. And it was discussed that the family members are usually the persons that aren't in agreement with the treatment plan or, you know, maybe palliative care. So that's when the ethics committee is involved. Did I say everything right, guys?
Yep.
Okay, good.
Melissa, does somebody from your group want to speak?
Yeah, Deb from HPNA Phoenix will talk.
Yeah, and we discussed too that there often is either dysfunction or conflict in families, even though to the point that that impacts the ability of the surrogate decision maker sometimes. So we were thinking that is when an ethics committee would be particularly helpful, because they could be positioned as more of an objective third party to the situation. I can't remember what am I missing from the group as far as what else we discussed.
I'm just gonna, I don't have the ability to mute everybody. I think somebody's unmuted. I just wanna, I think you're, okay, perfect. Thank you, Deb. Thanks so much. Did anybody from our group wanna speak to what we spoke about? From my group?
I think when we were,
Okay.
we kind of addressed waxing and waning, I think, to the general. We didn't really specifically do the ID population, I would guess.
Mhm.
But that's when we talked about with someone with waxing and waning capability would be the ethics committee that would have to help with that.
Mhm. Yeah. And I like the part where you guys mentioned about the triggers. We talked about that. It was mentioned in our group that we have to be mindful of the fact that these are people who may have sensitive topics that may trigger them to have, you know, more, you know, deeper reactions than you or I might be from the same conversation. And that the people who are with them 24 hours a day would be the ones to guide us in knowing what triggers would, you know, be harmful to them rather than helpful and cause more of a burden to them. So, so yeah, that's,
I would
you
like
know, that's a
to
lot. Yeah.
add a point about the section on should we include that person in decision making. And I think if we're viewing this from the lens of providing compassionate care to these people, I think that it's very important how we talk to them, whether they're going to be the official decision maker or not, and bringing the conversation down to a level where they can hopefully understand something of what's going on, and at a level where they can relate to it. And even though they may not be the official decision maker, I think how we have those conversations and how we interact with the patient is going to preserve their dignity and preserve their feeling of being cared for. And I think that they would perhaps be more cooperative with whatever care we decide to give. So I think it's important to kind of have a double lens on that, even though this person is not really capable, he or she is still a person, and we could still respond to what we are seeing as their needs. So
Yes, definitely. Yeah, we have to meet people where they are, right? In a nutshell,
Yes.
that's what we do.
Yeah, I'm really happy. I've got a lot of things rolling around in my head right now because I'm planning on some different activities for my students regarding the ASD population. And I think that this is so important, this discussion we're having right now, because this is going to grow. Our population, right now, in terms of children, 1 in 36 are born somewhere on on the spectrum with ASD. 1 in 36 in our nation. So these people are going to grow up. They're going to need all kinds of services. They're going to need our healthcare services. They're going to need hospice and palliative care at some point. And I think that this is like we're forward thinking right now by doing this. So I want to thank you so much because it's really triggering a lot of thought in my mind. And I mean, granted, I might not be the one caring for them because of my inherent age, but it's something that we need to pass on to the nurses who are following behind us, and to teach them and to have them learn how to care for, whether it be a patient with ID or a neurodivergent um, condition. So thank you. I just wanted to get that in there because I got all this stuff going on and I'm very excited about being here, even more so than when I came on this evening. So thank you.
Thank you. Thank you so much. All right. So anything else, Tracy? Can I present our conclusion?
I think you can.
Okay.
I just want to say one thing though.
Yeah, of
I'm
course.
with Donna. While I was working on this this presentation with you all, I learned so much from it. And it has me already looking at each patient encounter that I have in a different light. Although I always thought that I was saying the patient's competent, and I found out that I was using that word inappropriately. But either way, that's really important to me, that whether or not they have their decision-making capacity, if they're able to make their own decisions. And that's always been important to me. But I learned a lot in this, and I am also very energized by this case study. So you can conclude now.
No, that's great. No, I'm really happy that we're all getting something out of it, because it is a complexity to our lives, right? When we have these challenges, I find that it makes, like you're saying, makes my thoughts start racing. Like, how should I handle this, and all of those different things. So in conclusion, there's three things I think.
I'm sorry,
Yeah.
Leslie, can you see my slide?
I see group discussion.
Oh my God. Ay. Okay. All right, continue with what you have.
Okay. In conclusion, we're hoping that you've taken away three big things. We want to make sure that we all are involving the individual with differing abilities as much as possible in the decision-making process, thus facilitating their right to autonomy. That is, our key. I think all of our focus is always patient-centered care. And then also we'd like to hopefully send you with some tools that we are able to use to determine capacity to ensure the patient is able to make informed healthcare decisions. So all of the questions that were on those slides, the slides will be on Nursing Network, so you can take a look at them. Because what I found when I was doing this preparation for this was, it's one thing to know I need to ask questions to determine capacity. It's another thing to know what questions to ask, So for me, those two slides were critical. So they helped me to kind of pull it all together. And then the last thing we hope that you take away from this is that, utilizing surrogate decision makers between family members, hospice and palliative care teams, and direct care providers, we want to make sure that we keep that in mind, because that's the best way to make sure that we keep patient-centered care through all phases of a person's life and their illness. So that is the conclusion. And now we have our last door prize. I hope Adrian can can help us with that.
Leslie, can I just say something before we
Sure.
continue with the door prize? I just want to make sure in the conclusion and, takeaway, the takeaways from this program, I don't know that we did emphasize enough that we have to include the people who are taking care of our patient in their decision making. So most of the time we forget that, especially for those people who are living in group homes, who grew up in group homes, they have people who care for them, who knew them from when they were young, who takes care of them on a day in, day out basis. Sure, we have decision makers, surrogate makers for the patient, but at the end of the day, those people who are taking care of them are the ones who know the patients the most. And so in our meetings, family meetings, to make decisions for our patients, we have to make sure that those people are included in the decision making. I just want to make sure that we put it out there.
Yes, no, that's huge, because
Yes.
those are the people that we talked a little bit about that we tend to look at the person who's at the bedside with the patient, right? And usually in a situation like this would be the person that they're with all of the time, but also taking that into consideration that those are the people who really know them the best.
Mhm.
Yeah.
And provide them with bereavement services as well. They
Mhm.
shouldn't be forgotten.
Yes.
So you're
Yeah.
absolutely right.
Right. Yes, you're absolutely right. I had a situation at a nursing home that I worked at where I felt it was necessary to have bereavement services for the PCAs, because they're caring for these people day in and day out. They're like little families. And I don't think anybody ever realizes how those caregivers are affected by, serious illness and death of their residents and their patients. So yeah, that's a really good point, the bereavement part of it. All right. Are we ready for door prize number 2?
I think we are. So I took Donna's name out. Again, the person has to be here in
Okay.
order to send the $25 Amazon gift card that will be emailed virtually. So you'll get a virtual card. Is there anyone in the room that is opposed to receiving an Amazon card? Anyone? Is there anyone who's on like Amazon?
Blackout?
Yeah. Anybody not? Just speak now or forever hold your peace.
Is anyone banned from Amazon like me?
Yeah. All right, here we go. I'm gonna spin it. You saw me shuffling, and here
Yes,
goes
we
the
saw you
spin.
Okay.
Is Carolyn here?
Carolyn Claire. I have not seen a Carolyn.
Okay, we move her and try again. Good luck, everybody. How about Christina?
I did see a Christina.
Is Christina still here?